Thank you. Thank you. Good afternoon, everybody. My name is Ken DeSergio. I'm the co-project deputy director for the National Quality Improvement Center for Collaborative Community Court Teams with the Center for Children and Family Futures. We are excited. We want to welcome you to today's orientation webinar on the opportunity to apply to become a demonstration site with the National QUIC. We're excited to have you. We're excited about the opportunity to work with court teams to address the needs of infants, children, parents, and caregivers affected by substance disorders, those infants and children affected by prenatal exposure, and to implement the CAPT amendments as a Child Abuse Prevention and Treatment Act as amended by the 2016 Comprehensive Addiction and Recovery Act. A couple of housekeeping items. Our agenda is going to be very tight today. If you have questions, please use the chat line. You see it in the bottom corner of the screen. Please enter your questions there. I don't know that we'll have time to open the mics up, open the lines up for question and answers due to having a very tight agenda. We will write up all of the questions that you submit and put answers in writing and send those out to all the participants on today's webinar. We recognize the impact of opioids, methamphetamine, cocaine, and other substances that it's having on our communities, particularly on infants and children and families, and the child welfare system. So we really appreciate and are grateful for the opportunity to work with demonstration sites and communities to address the special needs of these infants and children. The National Quality Improvement Center for Collaborative Community Court Teams is a program of the Administration on Children, Youth, and Families, the Children's Bureau. And just to highlight today's agenda, we're going to cover the background intent of the goals of the initiative. The initiative is out of the Children's Bureau, comes out of the office that oversees court improvement programs, and we are really appreciative of the opportunity to be able to implement the National Quality Improvement Center for Collaborative Community Court Teams, along with the partners that you'll be introduced to today as well. We'll give you a little bit of background about our approach, the Center for Children and Family Futures, and the partners that we've engaged to assist with the implementation and provide technical assistance to the demonstration sites. We'll highlight the demonstration site opportunity and the site application process and the resources that are available as you contemplate whether to apply to become a demonstration site for the Quality Improvement Center, under the Quality Improvement Center. Today's presenters will be Dr. Nancy Young, the Executive Director for the Center for Children and Family Futures and the Quality Improvement Center for Collaborative Community Court Teams Project Director. In addition, Dr. Terry Tobin, the Director for the Center for Florida Research and for Research and Evaluation at Advocates for Human Potential, and our lead project evaluator, and Tracy Watkins, Child Welfare Program Specialist with the Children's Bureau, the Administration on Children, Youth, and Families, and the project officer for the National QUIC as well. And with that, I'd like to turn it over to Tracy.
Thank you, Ken. Good afternoon, everyone. As Ken just indicated, I'm Tracy Watkins. I'm the Federal Project Officer for the National Quality Improvement Center on Collaborative Community Court Teams with the Children's Bureau, and specifically in the Division of Program Innovation, which administers discretionary grants. So I'm going to take just a few minutes to go over the background and intent of the Quality Improvement Center. Because it is such a very long name, I am just going to refer to it as the QUIC, or the Quality Improvement Center. I apologize in advance for my cold voice. I am recovering from a cold, but hopefully I can get through this so that you all can hear me and understand me. The Children's Bureau just recently awarded the grant through a cooperative agreement to the Center for Children and Family Futures to implement this QUIC. The intent initially is to build on the work of the Quality Improvement Center infant toddler court teams to specifically address the needs of infants, young children, and their parents or caregivers affected by substance use disorders. And specifically, this new QUIC, what we liked about the initial QUIC was that the structure and the importance of a collaborative work with courts, which is something that is going to be essential for those participants who participate in this project. Again, the intent was to support demonstration sites that establish or enhance collaborative community court teams to design, implement, and test approaches to meet the requirements of the Child Abuse Prevention and Treatment Act, or CAPTA, as amended by the Comprehensive Addiction and Treatment Act of 2016, also known as CARA. And of course, this is the comprehensive federal legislation to address the opioid epidemic. Some key components or primary changes that were the result of CARA is that, one, it further clarified the population to infants born with and affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol spectrum disorder, specifically removing the term illegal so that it would be inclusive of all drugs, not just illegal drugs. Secondly, it required a plan of safe care to include needs of both the infant and family or caregiver. Thirdly, it specified data to be reported by state to include such thing as number of infants for whom a plan of care was developed, a number of referrals made for services, etc. And lastly, specified increased monitoring and oversight for states to ensure that plans of safe care are implemented and that families have access to appropriate services. So those are the key things that we want the demonstration sites to be able to address through this program. Demonstration sites must include intensive collaboration among the following agencies. Again, if you recall, that is one of the key factors that the Children's Bureau will be looking to hope gets implemented as a part of this program. So as Ken will talk about a little later in the presentation, there are sort of two pathways that we're looking to bring demonstration sites on board. One is through the state or tribal government oversight level. Memberships would include the Court Improvement Program, which would serve as a lead agency, as well as the Child Welfare Agency, Substance Use Disorder Treatment Program, Public Health to include maternal and child health, or tribal government consortia. Another approach would be to come in as a local court team, and the membership of there would, of course, be substance use disorder treatment and mental health providers, again, child welfare agencies, maternal and infant health care providers, hospitals, and attorneys. Again, in either of these two scenarios, we would be looking for the Court Improvement Program and or the local courts to serve as the lead agency. Now, of course, this list is not comprehensive and may include other important partners at both the state and local levels, determining on your specific jurisdictions and who you deem to be important team members. Moving on to some of the goals that the QUIC is charged with is first implementation, and that is to enhance the capacity of CCTs to appropriately implement the provisions of the Comprehensive Addiction and Recovery Act, or CARA, amendments to the Child Abuse and Prevention Treatment Act. Secondly, regarding capacity, to enhance and expand the CCCT's capacity to effectively collaborate to address the needs of infants, young children, and their families or caregivers affected by substance use disorders and prenatal substance exposure. Thirdly, sustainability. We want to sustain the effective collaborative partnerships, processes, programs, and procedures implemented to achieve the goals of each demonstration site. And then lastly, dissemination. We want to be able to provide the field with lessons they can apply about effective practices for implementing the requirements of CARA and meeting the needs of children and families affected by substance use disorder. We hope to achieve those goals, of course, through the implementation of the demonstration sites. So let's look at some of the target groups that this project will focus. The target population, of course, infants, young children, and their families or caregivers affected by prenatal substance exposure and substance use disorders that the collaborative community court teams will serve. The technical assistance targets will be those selected teams and their partner agencies, including, again, the child welfare agencies, substance use disorders and mental health treatment agencies, healthcare providers, and other key relevant child and family serving agencies. And the dissemination targets, of course, would be the larger field of collaborative problem-solving courts and their system partners across the country. We at the Children's Board are also very excited, and we hope that we will get some really great applications to move forward with this project. With that being said, I will turn the presentation over to Nancy.
Thank you so much, Tracy. We appreciate your leadership with the QUIC and looking forward to this next phase of site selection. And thank you to all of you that joined today to learn about what's going on with the QUIC and the application process and what we'll be looking for in this next application. Let me back up just a little bit for those that may not be familiar with the Center for Children and Family Futures. We operate several different technical assistance and evaluation programs at CFF, the broader organization. In particular, we're the technical assistance provider to OJJDP on family treatment courts, so come with many years of experience with collaborative courts related to family drug courts, family treatment courts, several research and evaluation projects that have been largely focused, again, on family treatment courts. I'll move to the right. Prevention and Family Recovery is a foundation-funded initiative that we are now working with our second set of local courts that are implementing evidence-based practices in conjunction with their family treatment court to improve parenting and infant and young children's services. And then the largest of the technical assistance programs is the National Center on Substance Abuse and Child Welfare, under which we have a variety of technical assistance programs. Many of you, I'm sure, are familiar with regional partnership grants, and there have been now 4 rounds of regional partnership grants funded. Also, the in-depth technical assistance program that about 4 years ago began a focus specifically on state strategic planning related to this population of infants with prenatal substance exposure. So we have about 8 states that we have been working with intensely over the last 4 years to understand the lessons and the strategies and the challenges to address this population in child welfare and the courts. And then when CARA was signed into law, worked with about 6 states continuing their in-depth technical assistance to identify challenges and barriers to some of the things that are challenges for courts and for child welfare agencies in reaching into the healthcare arena in particular as babies are born with the requirement that there be a notification to CPS. So we wanted to give a little bit of that in terms of the breadth of the experience. The project staffing, you will hear a bit about the various subcontractors and consultants that are available to you for the technical assistance components of the project. And you see the names that are associated with that from Children and Family Futures and the subcontractor organizations, including the National Center for State Courts, the Advocates for Human Potential, and subcontracting TA with the Center for State through the American Bar Association. And I won't go through all of the detail, but these are names I'm sure that are familiar to many of you, along with the Tribal Law and Policy Institute. And we'll talk a little bit about what they bring to this technical assistance program in a moment. And you also see some subject matter experts that, again, many of those names will be familiar to you if this is a population that you have been working with infants with prenatal exposure. These are some of the experts in the field related to that. The training and technical assistance, the expertise, I've run through at a very high level, and the organizations that are part of our collaborative to ensure that the Center for Children and Family Futures has the breadth of experience available to sites for a variety of TA, evaluation, court processes, best practices in court, help with tribal applicants and tribal courts, as well as the application of ICWA requirements in the court system and in child welfare more broadly. I mentioned ABA, Center for Children in the Law, and the engagement of attorneys and judges, and they will be available for technical assistance to the quick sites, as well as that list of subject matter experts. And certainly as we learn more about the complexity of implementing the changes in CAPTA related to infants with prenatal substance exposure, we will be looking for if we need to add to that for subject matter experts to ensure that we have the expertise that is needed by all of the quick sites. We also wanted to just highlight a couple of things related to the breadth of experience that will be available to you. I've mentioned the National Center for State Courts, and they are the agency implementing the Capacity Building Center for the courts. Advocates for Human Potential, and in particular some of their evaluation work in the Moms Do Care evaluation, and the National Alliance for Parent Representation. We've worked with AHP in a variety of evaluation settings and are thrilled that they joined our team as the evaluator. Others with the Tribal Law and Policy, again, Tribal Healing to Wellness Courts, the treatment guidelines that the second edition is out now, and their partnership with ABA and others in the Capacity Building Center for Tribes, and again, the American Bar Association and their lead agency as the Capacity Building Center for Courts. All right, let's move forward. The technical assistance approach. We will be creating change teams and support from the experts in the field that you saw the names of the experts that are already selected, and again be augmenting that list as needed. We're going to talk a little bit about the frameworks for collaborative courts and infants with prenatal exposure, and then the demonstration site engagement. After these three sections, then I'll be turning things over to Terry to talk a little bit about the evaluation, and then again, Ken will be talking more about the selection process. So let's talk about the change teams. Intensive training and technical assistance from a dedicated quick change team to support the design, implementation, and testing of approaches. We know there are a variety of ways in which states and local communities are coming together to look at those requirements in the amendments to CAPTA, and some are very challenging, and we anticipate that that's going to take some time to test out certain approaches and back up a little bit and then implement. The change teams will be assigned to each of the court sites. That will be two senior level change leaders or change liaisons, one from CFF or National Center for State Courts, who are the programmatic, if you will, technical assistance providers, and then Tribal Law and Policy for those sites that are tribal courts, and then a second on the team that is a second member on the team that is supported by AHP, that are skilled in CQI and how to make sure that we're looking at process and outcome evaluation, and importantly, building each of the sites' performance monitoring capacity. That quick consultant pool will then be tapped as needed as changes, as challenges are identified in a variety of ways, either through web or telephone consultation or on-site consultation as needed. So that's the sort of broad approach to the change team. We also have had some experience over the last 15 years in particular in developing the technical assistance approach to collaboration through the National Center on Substance Abuse and Child Welfare. And very early on put out the essential components of collaboration. Some of you may recognize this from the documents that have been created from the Technical Assistance Program for Family Treatment Courts under OJJDP with that foundation of a shared mission and vision. We find that when local communities skip over that part, or they don't revisit their mission after a few years and check in with their partners, that things can sometimes go sideways a little bit, or sometimes just languish and not be fully implemented. So that foundation of really agreeing upon what are the mission statement, what is the mission statement, what is the vision about what the collaborative is to be focused on. And then some specifics about agency collaboration, some of the structure, if you will, of collaboration, and some tools that are available in each of these areas to strengthen those structures, to be sure that that is in place to support local courts and the practice that needs to be supported with some concrete ways in which, again, barriers are identified, challenges are identified, solutions are tested out, and that the client supports often mean that identification and assessment, the timing of that becomes so critical, particularly when we're talking about infants and the time clocks, about making sure that the developmental needs of infants and children are being met at the same time that the time clock of treatment and recovery for parents are being met, as well as then the community support that's needed to sustain recovery, and even identifying how we are focused on the whole family and the whole family's recovery whenever that is appropriate for birth parents and for other constructions of family when that is needed. And that is focused largely on what are the shared outcomes. By that we mean from all of the community partners that are needed to provide these services, what are the outcomes that are agreed upon that will be collected, the data to be collected, the dashboard to be monitored, the ways in which we really strive to be data-driven in our decision-making. Another framework that we find very useful, this actually was published about a decade ago, the first time in a publication from, again, the National Center on Substance Abuse and Child Welfare, but it's also been published in part of the Office of National Drug Control Policy Strategic Plan a couple of years ago. We've used it extensively in our programs of in-depth technical assistance, which really the intent is to identify that I think if we listen only to the media, that third level down, identification at birth, is when babies are recognized with prenatal substance exposure. And that's certainly true at the time of birth. But knowing that communities can have a focal point of prevention and awareness pre-pregnancy for women of childbearing age, what would that look like for a collaborative to be focused on prevention and awareness? What would that engagement with prenatal care providers look like so that there was a plan in place before the birth event so that it wasn't a crisis at birth, but rather the planned implementation of what does that mean for this particular family who has perhaps been identified in advance of birth, so that that planning can be put in place, and the plan of safe care that is identified in CASTA can be agreed upon before birth, so that that safety is ensured for the infant, that recovery services are in place, treatment services are in place, and engagement of the larger community in supporting this new family. And then services at that fourth level of engagement, certainly in the immediate postpartum period, to again ensure the infant safety and respond to the infant's needs, and older children in the family if there are, and then also the treatment needs of the birth parents, and as CAPTA amendments remind us, the family or other caregivers, to be sure that when there are foster parents that are part of the plan of safe care, or importantly, kin providers, grandparents, and aunts, how are they involved in that plan of safe care? So that fourth level of intervention in that postpartum period, and then infancy and beyond, as we know that some of the children with prenatal substance exposure may have the need for developmental interventions. How do we make sure that the Part C providers and home visiting providers and the others that need to have a supportive role for this young family, how are they engaged in this entire process to ensure that, again, that the safety of the child and the recovery of the whole family is identified and responded to. So that framework has been around for a while. If you haven't seen it before, I would encourage you to email us to make sure that you have that information and to think about that as you're thinking through your planning processes of who you need as partners if you're focused on these various 5 points of intervention. All right, finally, the demonstration site engagement. After this initial period of determining your collaborative, your goals, your priorities in the communities and in the states as the applicants, there are various ways in which the change leader teams will be engaging with each of the quick sites. It can be with conference calls, on-site TA, and visits. I mentioned bringing in those experts to your community if needed. I've already, I think, put our friends at the ABA on notice that most sites that we work with need technical assistance from attorneys to engage children's attorneys and to engage parent representation. So we're looking forward to being able to engage them in some of that TA. We will be conducting an all-sites meeting for the quick sites on an annual basis and be creating some opportunities for distance learning with every other month webinars and making sure that there are ample times available for the quick sites themselves to be able to share information about their challenges, their successes, what they're working on, how to share information across the sites about what worked with a particular hospital group or OBGYNs or pediatricians, how they are engaging with this sometimes new set of collaborative partners that can sometimes be challenging for attorneys and social workers and substance use treatment agencies to be in a collaborative and reaching into the healthcare arena that is called for in CAPTA to ensure that there is a notification that's made when a baby is born who is affected by substance abuse, experiencing withdrawal symptoms, or a fetal alcohol spectrum disorder. So that's a brief synopsis. I apologize again for that backup and repeat, but I think I recovered okay. And I will turn things over to Dr. Tobin to share with us information about the evaluation.
Thank you, Nancy. Hi, everybody. As Nancy said, I'm Terry Tobin with AHP, and I'm leading our team in conducting the evaluation component of the project. Like Tracy, I apologize for my cold and what it's doing to my voice as I take a few minutes just to give a very brief high-level overview of the evaluation. We designed it with a few key features that are listed here. It's really all built on a strong conceptual framework to start. We have integrated formative process and outcome components that are going to let us look at implementation and study how that's going, learn about the site services and activities that are being implemented, and really to identify and share innovative models, strategies, barriers, and lessons for everybody to learn from. We'll conduct an evaluability assessment to start, really looking at each site's capacity to even do this, to collect and submit the data that we've specified in the evaluation plan. And we'll use the results from that assessment to really finalize the plan and to provide TA that Nancy mentioned to all the sites to be able to support it and to be able to participate and be effective in the evaluation. We use a mixed methods approach that really uses the best parts of both qualitative and quantitative methods in analysis. Using both of those lets us make sure that we're having systematic data collection across the site and comparing how it's going across, but it also allows us for a more nuanced exploration of site-specific activities. So the combination works well. It's a multi-level design that collects data from on all the different perspectives of those who are involved in implementing the various projects at the site. And we also all try to maximize the use of existing data rather than reinventing the wheel and creating more burden. We work really hard with the Children's Bureau and the site to identify secondary data sources that you already have access to, work on data sharing agreements and getting those into place, and making sure that we have secure data transfer and data submission protocols as part of the plan. We use an analysis plan that takes all of this that I've been talking about and helps us really account for the complexity, as you might imagine, of studying all 15 sites, which have both common and unique goals, and really making sense of it all in terms of what everyone is doing and the wide range of contextual environments that they're implementing the projects in. And then finally, we operate with supporting data-driven continuous quality improvement, or CQI, reporting. And all of that helps us capitalize on the opportunities that are there to inform the feasibility, utility, and sustainability of the site's efforts. I'm going to talk a little bit more about the CQI approach on the next slide. At the heart of the CQI process, what we're talking about really is a cycle that just keeps looping around throughout the project, where in the cycle we'll share the findings that emerge from all of the data collection and analysis activities that we do. Those findings can then be used to make adjustments on the site side, and then we'll assess the impact of those adjustments and keep feeding the results back as we go along. And it all just keeps looping around again and again. So that's really just a quick high-level overview on the evaluation component, and I'm going to pass it back to Ken now and he describes more of the process.
Thank you, Terry. I appreciate that. This next segment is, I'm going to present the nuts and bolts of, or at least a highlight of the nuts and bolts of the demonstration site opportunity. We wanted to give you an understanding and appreciation for the depth and breadth of the Quality Improvement Center and the technical assistance approaches, and will be available to all the demonstration sites before talking about the request for proposal and our approach to this. At the same time, the RFP that comes out in, as I'll talk about in mid-January, will have a lot more detail around the areas that I'm presenting over these next several slides. Tracy alluded to this in her comments in discussing the partners both at the local court level as well as the state level. And so we essentially are establishing two pathways for eligible applicants to participate in the as a demonstration site and to apply to become a demonstration site. So the first pathway is for state or tribal court improvement programs or tribal governments. For both of these pathways, demonstration sites will be court teams, but as you can see here, you'll have several options for whom the lead agency or applicant can apply to be. Under the first pathway for court improvement programs, tribal court improvement programs, or tribal governments, state or tribal CIPs would be eligible to submit an application in collaboration with local courts. The CIPs or TCIPs would be the lead agency and could submit an application in collaboration with up to 3 local courts within their jurisdiction. If a tribal court's jurisdiction doesn't have a court improvement program, and really most tribes don't, I believe there are only about 7 tribes that have tribal court improvement programs, tribal governments or an agency that the tribal government may could designate as a lead agency, then could submit an application in collaboration with tribal courts in their jurisdiction. On the second pathway for a potential applicant includes local courts, tribal courts, or community-based agencies. So if a state court improvement program chooses not to submit an application, then local courts in that particular state or tribe would be eligible to submit applications directly to the National QUIC through the Center for Children and Family Futures with letters of commitment from the state or tribal court improvement program. Other local agencies such as child welfare, substance use disorder prevention and treatment programs may also submit applications as the lead agency in partnership with their local dependency court. Local agencies who apply to be a demonstration site that are other than a dependency court obviously would require a letter of commitment from the local court. If a tribal court improvement program or tribal government agency chooses not to submit an application, tribal courts would be eligible to submit applications with letters of support from their TCIP or tribal government. Other local tribal agencies such as child welfare, substance use disorder prevention and treatment, tribal health agencies may also submit applications as the lead agency in partnership with their local courts. Obviously, again, local agencies other than a court will require a letter of commitment from their local court. We believe this two-pathway approach will ensure the engagement of state and tribal CIPs and also provides an option for local and tribal courts and dependency court partner agencies to apply as a demonstration site. Recall one of the intents that Tracy discussed earlier in the presentation regarding the dissemination of effective practices that the demonstration sites embark on and are able to exemplify and demonstrate, and the involvement of state court improvement programs as well as tribal court improvement programs, either as lead agencies or as support agencies for local jurisdictions, really helps that dissemination process and the infusion of those best practices in other courts within their jurisdiction and certainly among courts throughout the country. So the National QUIC has the opportunity to work with 15 demonstration sites. The engagement with the demonstration sites will be through September 30th, 2020, about 30 months. And as we'll see it in a moment, we anticipate selecting those demonstration sites by the end of March in 2018. The mutually binding agreement would include the responsibilities of the demonstration sites and the QUIC team as well, and the QUIC community collaborative court teams, as well as agreement as how the funds are to be utilized. And you can see on this slide that there will be a funding allocation of $70,000 annually per demonstration site. That money could be used for these following purposes. Travel and per diem. There will be an all-sites meeting in Orange County, California for all of the demonstration sites in year one of the grant program or the demonstration site program. And we anticipate that meeting occurring sometime this summer. We're just working to make sure that it doesn't conflict with other meetings that the Children's Bureau may be scheduling for discretionary grantees. The other potential uses of these funds include staff training on evidence-based parent-child interventions, developmental or other therapeutic services for children, or a court coordinator or plan of safe care coordinator. We know that in previous QUICs and under the QUIC under the infant and toddler courts that court coordinator, some of the funding support was for a court coordinator, and certainly that is an allowable use of the funds that the demonstration site will receive, but cannot supplant any existing funding or an existing capacity that may already be in collaborative community court teams. And then the funds could also be used for evaluation support. Also, a word about Plan of Safe Care coordinators. Plan of Safe coordinators and our work with sites, particularly addressing the needs of infants with prenatal exposure and implementing the requirements of Child Abuse Prevention and Treatment Act, is often involved in the development of the Plan of Safe Care, in coordinating the information across the various systems that are working with families, particularly across the medical community, maternal and infant health care providers, as well as courts, as well as child welfare and child protective services, as well as the other community services such as substance use treatment providers and medication assistance treatment providers. So that becomes a really important position. We recognize that states could be in various developmental stages in implementing the requirements of CAPTA and CARA. They may or may not have implemented Plan of Safe Care coordinators in your jurisdiction, and so we see that as a viable option for the use of these funds. Of course, we will work with the demonstration sites and with the court teams on developing sustainability strategies to continue the support provided by these funds. We don't see these funds supporting legal counsel, and we'll work with the demonstration sites once they are selected to really, there are other needs that these funds could be used to support in identifying those and then including those in a mutually binding agreement. So a little bit about the site application process. As I mentioned a few minutes ago, we anticipate the request for proposal to be released in January of 2018, probably toward the middle of the month. Eligible applicants will submit a brief 5 to 7 page narrative proposal. We're going to limit this to 7 pages. The teams that could apply could submit a request for proposal. Certainly would include established court teams, but not limited to established court teams. So a new team could come together and submit a request for proposal, and we'll accommodate that in our review process as well. But would have to be demonstrated, the team that comes together would have to demonstrate a strong partnership and a commitment from the partner agencies, recognizing that the team would be coming together for the purposes of the QUIC, but we would look for a strong commitment from those agencies in the event that the team has no track record, has not come together previously. Certainly we look for that same level of commitment from an established collaborative court team as well. We will review the proposals that come in, again, about a 30-day time for submitting those proposals. So we anticipate those proposals coming in sometime around mid-February, toward the end of February. Then applicants with the strongest proposals will be invited to participate in a teleconference consultation assessment with the QUIC team and our partners. And the purpose of that teleconference call will be for both of us, both potential applicants, you as the applicant, as well as the QUIC team, to ask questions, to discuss your proposal, to clarify what you may have written in the proposal, and an opportunity for you to get additional information and clarification about the work of the National QUIC and any questions that you might have in preparing the proposal and engaging with the QUIC team. Our team will consult with the Children's Bureau in making the final selection of demonstration sites, which we anticipate occurring by the end of March 2018. And that process will take into account everything that you submitted in your proposal, our review process, and you'll see in a few minutes on the next slides the content and that we're anticipating in the request for proposal, as well as the review criteria. So applicants must demonstrate within their application readiness, need, readiness, and commitment. This is the 30-month duration for this program and for the demonstration sites. Is really not a long period of time to implement practice changes to address the needs of infants and families, particularly to implement the CARA amendments to the Child Abuse Prevention and Treatment Act. it's important that that each applicant have the buy-in from leadership of their agency and leadership from partner agencies to support this work, as the demonstration site work may well include practice changes, and it should include practice changes, new ways of doing business to address the needs of this population. I'm going to talk a little bit about each of these areas to give you an idea of what we're talking about when we talk about need, readiness, and commitment. So when we talk about need, many, as I mentioned earlier, many communities have been affected by the opioid epidemic, and other communities have continued to be affected by methamphetamine and cocaine. These need bullets only highlight examples of need that may be prevalent in your jurisdiction. The RFP will describe in more detail, for example, current trends, needs and concerns in your jurisdictions as it relates to infants with prenatal exposure. We will ask you to describe how these needs have affected the various systems in your jurisdiction using data, the data that may be available. Some of the need questions and the particular systems that work with these families. For instance, from child welfare, has there been an increase in the number of infants with prenatal exposure? Has there been an increase in the number of infants in out-of-home care, particularly infants obviously under age 1, and we see that a larger percentage of children in out-of-home care are children under age 1. Regarding the need for treatment, is there an increased demand for treatment for pregnant women? Is there a waiting list for these services? What's the availability of family-centered treatment, the ability for women or parents to enter treatment with their children, to have the needs of the total family, the total needs of the family addressed through family-centered treatment. What's the availability of medication-assisted treatment? Certainly that's the gold standard of treatment for persons with opioid use disorders, and how available is that? We know that there's significant challenges for the availability and access, not only to medication-assisted treatment, but to substance use disorder treatment, particularly in rural areas. Looking at the medical community and healthcare providers and the hospital systems, has there been an increase in infants experiencing neonatal abstinence syndrome? Has there been an increase in length of stay in NICUs or general pediatric wards? We know that there's been significant increases in both NAS lengths of stay, the number of babies with NAS in hospitals, increasing Medicaid expenditures and putting pressures on the healthcare system, not to mention pressures on the child welfare system. And then what are the services and supports and other needs of pregnant and postpartum women with substance use disorders or infants and families and caregivers? Under readiness, we're really talking about the collaborative capacity that both Tracy and Nancy have spoken about, and really the foundation of that collaborative capacity to address the needs of these families. So we'll be looking for and enunciating in the RFP what we expect for team composition. How is your court organized? What's your governance structure in terms of a core team, an oversight committee? Who are the members of your team, and does it include the array of agencies and provider systems that are essential to serving this population of infants and their families? What collaborative processes are in place that support partner agencies? How is information shared? Has your collaborative worked through or plan to work through the confidentiality issues and requirements that are characteristic of both the substance use disorder treatment system as well as the child welfare system? What's the status of implementing CAPTA in your state, local jurisdiction? All states have been given guidance from the Children's Bureau in terms of implementing the CARA amendments to CAPTA in 2016. We know that CAPTA has been around for quite a long time. The Plans of Safe Care have been around since 2003. A lot of the work that we will support you in is coordinating your implementation of those requirements of CAPTA with what is occurring in your local jurisdiction. Under the National Center, we are working with the Children's Bureau and SAMHSA to understand and take a look at how states are implementing CAPTA per CARA amendments in 2016, and we'll be able to coordinate with the state offices as well as the local jurisdictions so that strategies to implement CAPTA are consistent and coordinated with the approaches that a state has undertaken to make those changes and to implement CAPTA as well. In evaluation, what formal agreements or practices or protocols are currently in place to share data across systems, both at the case level as well as aggregate level? Terry mentioned the evaluation approach, so it's really what is your performance monitoring capacity or capacity to get information, particularly from child welfare, from the court, and from substance use disorder treatment, to kind of put those performance data together and to get a more complete picture of the performance of local courts. Commitment of leadership is just so critical in implementing this work and working on behalf of these families. As we've learned and as we've presented and discussed in recent years, when it comes to infants affected by prenatal exposure, there is no one system that really has the lead on addressing the needs of infants and families. And as Nancy said, in reference in the 5-point intervention framework, if you look at that framework, there are different systems involved with children and infants and women and parents, both at the prenatal level, prior to pregnancy, through birth at the hospital, and then what happens post-hospital discharge, and then as children enter toddler years and beyond. So that commitment it becomes vital from those partner agencies to work collaboratively to provide services, to strengthen the responses and the access to services to meet the needs of these families. We will ask you to articulate a mission and vision for your project. Recall that there are 2 specific areas of intent under the QUICs, and that's to specifically address the needs of infants, as we've talked about, and their parents or caregivers, and then testing approaches to implementation of CAPTA. So what will be required in order to do that? What do you envision as the end state? What will be different about how you serve infants, children, and families as a result of this work? Questions and next steps. I'll highlight a couple of summarize some of the things that we've talked about in these few remaining moments. So we will disseminate webinar questions and answers and encourage you to go ahead and pose any questions that you might have during the presentation. You can also send your questions to that email address that we've got posted in the second bullet. That's quick@ccct@cffutures.org. As I mentioned, the RFP we released in mid-January. You'll have a 30-day response time, and the teleconference consult and assessment will occur shortly thereafter, sometime toward the end of February into early March, and then the final selection notification for demonstration sites will occur in March 2018. The webinar will be posted at the website that you see posted, that you see listed on this last bullet. I want to highlight a couple of the resources that are currently available, and there are many more resources, but we wanted to just point out a few as you contemplate, as you think about being a demonstration site, a couple of resources that could help inform your work. If you haven't had access to these previously, this is a collaborative approach to the treatment of pregnant women with opioid use disorders. It's a SAMHSA publication that was released in the late summer of 2016. You can see the location of where that's located, where you can access that. It includes a lot of what we've been talking about, recommendations for collaborative practice, the 5-point intervention framework. It also has a series of surveys across the multiple systems serving families that can be used to assess current practice and to bring teams together and bring those systems together to serve families. Additional resources on the National Center website specifically to address opioids. We recognize that the opioid epidemic hasn't affected certain states to the degree that it's affected other states in rural areas, in Appalachia, in the Midwest, Ohio, West Virginia. But we also know that the Midwest and some Western states are still ravaged and impacted by methamphetamine. But here are some additional resources that we developed specifically under the National Center related to opioid use disorders. And then Children's Bureau policy resources. So the Children's Bureau has put out guidance through their policy manual, information memoranda, and program instructions around the implementation of the Child Abuse Prevention and Treatment Act as it relates to infants with substance exposure, guidance to states for submitting their annual progress and service reviews, and some suggestions for best practices as well. And then you see the contact info. Yes.
Ken, we do have a couple questions that I think we should address, and maybe we could leave that contact information slide up in case anyone wants to contact us, or send it to that email address that we showed on one of the prior slides. Questions that came in related to the state applicant. So it's anticipated that a state office would engage 3 to 4, probably more like 3 courts, that would be considered 3 local sites, so 3 sites. Each of those 3 sites would be an implementation site receiving the $70,000. So each of those local implementations. The state CIP would coordinate that, could be the applicant. We would anticipate that they would be the applicant naming their 3 to possibly 4 local sites in their state, but that the monies would be passed, would be a memorandum of understanding and agreement between the state and the local county for implementing that, or the state may have the administrative structure to administer those funds for the local court. That would be up to the state to decide. But it's not anticipated that a state would be the recipient of the implementation funds. It is that they would be selecting local sites. And in that spirit, I'll speak to tribes in just a moment, but in that spirit, this is a 1-week opportunity. We're going to move fast in this project, as you can tell already, but they wouldn't necessarily have to participate in the live webinar next week, but on the 19th of December, 1 week from today, at 2 o'clock Eastern, we'll be repeating part of this webinar, but gearing it specifically to Track 2. So if the state CIP did not choose to be an applicant, the local courts could be the applicant with an agreement from the state CIP that they would be aware of and participating with, looking at the lessons from the local court. So you may have 1 or 2 jurisdictions in your state that would be ripe for this kind of a project, but that the state office is not going to be the applicant. So they could apply directly through Track 2. And that webinar next week will be talking about that second opportunity. Similarly, a tribal CIP or a tribe administrative structure could be the applicant for a local tribal court, or a local tribal court could apply directly with the support of the tribal CIP or their tribe's administrative structure for making sure that they have, again, that same kind of buy-in at the 2 levels of implementation. We got that question a couple of times. I hope I covered both aspects of that. Ashe's giving me a thumbs up that was answering the question that came. And if it wasn't clear, please do email us for any further information.
Thank you, Nancy. There's another clarification I'd like to make too regarding tribal courts and state tribal court improvement programs. We recognize that the CAPTA and the that we've been referring to, the parts of CAPTA regarding infants with prenatal exposure, don't necessarily apply to tribes, right, as sovereign nations. However, we're working with a number of tribes in a state where they are implementing plans of safe care, not as a condition of following the statute, but as a quality practice in order to address the needs of infants and families, provide access to substance use disorder treatment, as well as interventions for the infants and toddlers. So while we've made significant references to implementation of the legislation, the application, the implementation of plans of safe care, the collaborative practices to provide access to services, to respond to the needs of families who recognize is equally as critical in tribal communities, in tribal nations, and tribal courts as it is in non-tribal jurisdictions.
Thanks, Ken. And we note that we're at our 1 hour mark, and we have a couple additional questions that have come in that we're not going to be able to get to on live, but we will be collecting those questions, sending out responses to that, along with, as was indicated, we'll be sending out the PowerPoint, so you have this for you to be able to share with others in your state or communities. Thank you all.
Thank you, Nancy. We do hope that you'll give serious consideration to applying to be a demonstration site and look for the request for proposal that comes out in mid-January. We appreciate your time today, and as Nancy said, do forward us your questions or inquiries or any other information that you may need as part of your consideration and planning process. With that, have a nice, good rest of the week, and we wish you all the best during this holiday season. Thank you.